please?
Yes.
Okay. Good afternoon, everybody, and welcome to the first of our Be Healthy Long-Term Conditions webinars. This one today, we are talking about diabetes, and we have a brilliant range of speakers with us to talk about diabetes and COVID, coping strategies, lived experience, and some things that are in place that can help you as well, especially during this difficult period. So we have with us today Professor Wasim Hanif, who's the Professor of Diabetes and Endocrinology from University Hospital Birmingham. We have Tony Kelly, who's a Diabetes Strategic Patient Partner and Diabetes Ambassador and Advocate. And we have Cam Padden, who's from Health Exchange. So just a bit of housekeeping before we get started. When you're not speaking, could you stay muted and turn your cameras off, please? This is just to help us with the bandwidth and the running of the webinar. If you have any VPNs, so maybe NetMotion or Cisco on your computer, probably helpful to turn those off as well. We really encourage questions and any pointers that you want information on throughout the webinar. We ask you not to jump in as the speakers are speaking, but if you think of something, drop it in the chat box and we will either pick it up at the end of each part or at the end of the questions time. Likewise, if there's things we can respond to in the chat, we'll do that too, just to keep you up to date and on track with things. If you've got a question that you'd like to ask but don't want to ask in front of everybody, if you email it into healthybrum@birmingham.gov.uk, we will respond to you as soon as we can, so probably later today. And as we've said, this webinar is being recorded, so we will be using it as a resource and sharing with other people to use as well. So just before we get into the content about diabetes, I mentioned Be Healthy in part of the webinar series at the beginning. So just a quick recap for any of you that haven't been on our other webinars. I notice there's a few new names booked on today. So Be Healthy has been established to help us all reach communities and professionals and to give some practical tools and information to pass on to people that you work with in community groups. The idea is that we can help you to support them to reduce their risk of becoming seriously ill from COVID-19. So alongside this webinar, we have a whole series, so cover messages around COVID safety, healthy habits such as physical activity and healthy eating, and habits that maybe would be beneficial if people could reduce, such as substance misuse or smoking. If you would like to book on any of the other webinars, so if you're not watching live today and unsure, the link at the bottom is how you can book on, and they're all on the council website. Alongside that, we have some resources that are available to use as well. So we have a checklist to a healthier you, which covers all of the content of the webinars and makes you think about the things that maybe you could do more of, or maybe reduce a little bit in your life. And these are translated into 20 different languages as well, so are available for you to download from the link at the same link as the booking. So that's enough about Be Healthy, and time to move on and focus on the subject today, which is diabetes. And over to Professor Wasim Hanif to talk about diabetes in COVID time.
Thank you very much, Stacey. Thank you for your kind introduction. I would like to thank Public Health England for giving an opportunity to be talking today around diabetes in COVID times. Now, before actually I start talking about my slides today, I just wanted to give you a couple of minutes to reflect about COVID and what has happened so far. Now, when the first wave of the COVID pandemic actually hit us in March, before the COVID came to the UK, China and Italy and certain parts of Europe were affected. So our initial understanding of COVID, which is perhaps still true today, was this was essentially a respiratory disease or a disease of the chest or lungs. And this condition disproportionately affected our elderly population. As I said, is even true today. But what we have actually known about this disease during the first pandemic, because during this time, a lot of research has happened and a lot of publications have come in. And what it has shown us is that although there is a respiratory component of the disease, equally, if not more important, is what we call the metabolic component of it. And when I talk about metabolic component of it, we are talking about obesity, we are talking about diabetes, we are talking about underlying heart disease or cardiovascular disease, underlying renal disease. So this together is what we call the underlying burden of disease. And this underlying burden of disease, which has existed in our certain communities, inner city communities, BAME communities, has resulted in them being disproportionately affected. Now, when unfortunately we're waiting for the second wave of COVID, what is really important for all of us is to try and address this underlying burden of disease in the communities. And this can be done by following a very healthy lifestyle. And through my talk, I'll try and see that how we could do to try and manage this uncontrolled burden or disease in our communities better. First slide, please. So what I have started off is the relationship between COVID-19 and diabetes. I'm not going to go into the details, but this is a collision and a collusion of two diseases. And this is something very important to really understand, that COVID and diabetes collide and collude to create a perfect storm. And that is one of the reasons why we get this disproportionate effect on people with diabetes with COVID. And there are lots of mechanisms. I'm not going to go into details, but it just shows that both these diabetes lend very well to each other. Next slide, please.
No, you didn't forward it to me, though. I did.
So if you look at the predictors of COVID-19 risk, so these are the patients who will be affected.
Again.
Can we just mute, please? So the most important factor is age. So as you get older, your risk of getting COVID or having not getting COVID, but having a worse outcome of COVID actually increases. Similarly, high BMI. So if you're obese, your risk actually gets worse in terms of your outcomes. Structural discrimination. So this is these are the communities that are disenfranchised and are not able to access health. These are the communities that get disproportionately affected. Behavior. So this is the behavior in terms of social distancing. Environmental pollution, vitamin D levels, which again affects disproportionately the BAME communities. There is a genetic component to it. Comorbidities, as I mentioned to you, underlying heart disease, ethnicity, occupation, certain occupations which are facing, or what you call them, people facing systematic increased risk. Housing, multi-generational living or intergenerational living also increase the risk. Similarly, male gender. So as you could see, there are lots and lots of factors that could add to the increased risk. Next slide, please. So when it comes to diabetes, and this is something very important to understand. So this was a very large study that was done in the UK of nearly 6 million people to really look at the risk of actually dying from COVID. Although the overall risk, or what we call the absolute risk, is small, but there is an increased risk. So if you've got type 2 diabetes, so this is the kind of diabetes which most of the population has, and it is managed by diet or tablets, your risk of dying increases twice or is double. But if you've got type 1 diabetes, this is the diabetes in which you require insulin for the rest of your life, the risk of dying when you compare to somebody without type 1 diabetes increases by nearly 3.5-fold. Now, what again is very important is that if you actually look at that risk, your risk of dying from COVID increases by nearly 9-fold once you are aged more than 80 years compared to somebody who's between 60 to 69. So as you get older, your risk increases. Similarly, if you look between female and male, your risk is double if you're a male. Next slide, please. Now, what I'm going to do is I'm just going to share some of our experience from Birmingham. So this is from the University Hospital Birmingham. This data has been updated. Now, at the time of publication of this paper, we had nearly 2,200 patients admitted on all the 4 sites of UHB with the proven diagnosis of COVID-19. Nearly 60% of them were male. Most of them, 70%, were of white ethnicity. And nearly 80% of them had comorbidity. Nearly 19% of the South Asian ethnicity, and these were the patients who were more likely to be younger. So in the South Asian population, the mean age was 61 years when compared to the people of white ethnicity, in which it was 77 years. In terms of comorbidities, the South Asians had nearly 28% of them had comorbidities when you compare to 16%. And this is probably the most startling revelation, which was that if you look at the prevalence of diabetes, nearly 30% of our white patients had diabetes compared to nearly 50% of our South Asian patients. So diabetes was an important factor in a vast majority of our patients who were admitted with COVID-19 to UHB. Next slide, please. Now, this is something, so this is another paper which we have done and we are about to publish, in which we actually looked into trying to understand whether all patients with diabetes had an equal risk or whether the risk was distributed. And what it actually shows was that if you had diabetes but had no complications, which means your diabetes was well controlled, you did not have heart disease, you did not have eye disease, you did not have kidney disease, your risk was nearly similar to somebody who did not have diabetes. So your risk only went up if you had a poor controlled diabetes, long-standing diabetes, or diabetes complications. So what does it tell us? So what it actually tells us is just having diabetes does not increase your risk. It is trying to get your diabetes well controlled, having a healthy lifestyle, and not having complications from diabetes actually can be hugely beneficial to you. So one of the messages that is coming out from our experience is it is not diabetes alone that increases the risk, but other factors or uncontrolled diabetes along with complications increase the risk. Next slide, please. So in terms of if you look at what are the factors that are actually driving towards COVID in terms of the outcomes, especially in terms of mortality or admissions to ITU, it is age. There's very little we can do out the age. The only thing we can do is try to protect our elderly population as much as we can. Second is male gender. Again, we can't do about in gender. But the other two factors which are very important, one is obesity. We can do a lot about obesity. We can follow a healthy lifestyle, try to, and I'm sure my other co-panelists will share with you how we can help to lose weight. Just following a healthy lifestyle, just trying to do that exercise can be a huge benefit. If you are obese, your risk is increased about 3-fold of either dying or ending up in ventilation. And the fourth factor is metabolic inflammation. When we talk about metabolic inflammation, we're talking about diabetes, we're talking about heart disease, we're talking about kidney disease. And again, if these can be managed better, we can take away 2 risk factors from COVID mortality and outcomes. Next slide, please. Now, again, this is very important thing, and I'm just going to try and explain. So if you actually look at all people with diabetes, What we really want to know is whether all people with diabetes have got the same risk or if there is a difference. I told you, if you've got well-controlled diabetes without complications, your risks are nearly as good as somebody with diabetes. Similarly, who are the people who do worst in terms of mortality or death from COVID? These are the people who have got newly diagnosed diabetes. So what do we mean? So these are the people who have been undiagnosed or present to the hospital for the first time with COVID along with the diagnosis of diabetes. So what does it tell us? So what it tells us is that if you have got increased risk of diabetes, so there's a risk score on Diabetes UK website, which the communities can do that will tell you the risk. So the risks are if you are overweight or obese, if you are from BAME communities, South Asian or Afro-Caribbean heritage, or if you have got one of the two parents or a sibling having diabetes, your risk of developing diabetes is very high, and therefore you should have a blood test to see whether you have got undiagnosed diabetes. So these are the patients. Again, the message to the community is that if you are at risk, get a test done by the GP to know your risk, because people with undiagnosed diabetes are the ones that will carry a very high risk. Next slide, please. So one of the big challenges for us, two challenges, I said to you, uncontrolled diabetes at the time of COVID is a big challenge because it increases the risk. But at the same time, there are lots of problems in managing diabetes. And the reason is most of our services, at least in the first 3 months during the height of the pandemic, were all towards the front door. So very little services were being offered in terms of routine care in the hospitals. Similarly, the primary care was not able to offer the services because of shielding and other restrictions, social distancing, and most of these consultations now tend to happen over the phone. So I think one thing we need to understand is there an increased risk of catching infections for people with diabetes, either type 1 or type 2? The answer is probably not. We don't know. They don't have an increased risk. But if they get an infection, their outcomes are poor, especially if they have got uncontrolled diabetes and complications. So what are the practical tips we can give to our primary care colleagues and to the community leaders? One is, it is important to communicate to the communities that managing diabetes and controlling diabetes during the pandemic is vitally important. They need to check their blood sugars to make sure everything is fine. There are certain therapies that may have may not be good, but these can be decided by the GPs. But most of the treatment they should continue. So don't stop any treatments that you're taking for the diabetes unless you get medical advice. The other thing is that our high-risk patients and older patients need to be followed up and looked after, because it is very vitally important, because they are the most risk. Next slide, please. These are some specific considerations of what we call sick day rules. So sick day rules are that if you've got diabetes and develop COVID, in 80% of the cases, it is mild, so it's not going to cause any problems, but there are certain therapies that have to be stopped. Therefore, you need to get in touch with your GP or a primary care physician. But importantly, if you're on insulin or have got type 1 diabetes, you need to check your blood sugars. And most of the patients will have an update about how to manage their sick day rules. Next slide, please. Next slide, please. So sorry. So this is my last slide, and this is something we have produced as an infographic. And yes, a lot of this is available from the website of South Asian Health Foundation in various languages, and it just tells you what needs to be done in terms of preventing this in both in the communities and in our faith centers. So thank you very much, and I'll be happy to take any questions. So
Thank you very much. Thank you. That was really interesting. And I think the key message there is that if you are in a high risk group from diabetes, it's really, really important that you do go to your GP and get a blood test. And also, I think that's a message that everybody listening can spread amongst the communities that they're working for, to try and help protect them as much as possible. I'm just watching the chat now to see if there's any questions coming in. It might be that people are taking a bit of time to get warmed up. So I think what we'll do is we'll move on to Tony Kelly. And if there are any questions that come in, would it be okay if we emailed them to you if there's any?
yes, please, because I have to leave. I've got another meeting.
No,
thank you very
great.
much.
Thank you very much. Okay, bye-bye. Right. And so welcome, Tony. So we introduced Tony at the beginning. He's a strategic patient partner and diabetes ambassador and advocate. Tony's got some great information today about living with diabetes and some tips and advice and things that you can do, and also going to share some of his experience too. So Tony, I will move on to your first slide for you.
Thank you very much, Stacey. Thanks for having me. I start off with a disclaimer, which says quite clearly that I'm not a healthcare professional. But since diagnosis some 17 years ago, 18 years this Christmas, I have never taken medication for this type 2 diabetes, which runs in my family. Mine's through physical activity and diet. So for the last 7 years, Diabetes UK heard of me. They trained me up as a champion, but I've moved on from them, and I'm now with NHS Birmingham Solihull Clinical Commissioning Group as a diabetes strategic patient partner, further enabling and sharing my work with others and in the community. That's a little picture of me as a little 5-6-year-old boy with a cheeky smile on my face. Next slide, please. This talks about hard to reach communities, and that just shows a scenery of hard to reach communities. Next slide, please. Right. Now, you will hear the word hard to reach communities. If you log on to Google, internet, what have you, it's there. It's a myth or a misnomer, which in my 8 years of doing this community engagement out there, I tend, when I hear it, I cringe, and I have to challenge people and say, please do not describe communities as hard to reach. They mainly are referring to the African, Caribbean, and Asian communities. And my response is, are they on Mars, Jupiter, in the rainforest, in the jungle, in the deep blue sea, or in the ocean? No community is hard to reach. It is up to us to get from out of our ivory towers or from behind our laptops and go and engage with communities. I do on average 140 community engagements per year as a volunteer, have done for the last 8 years, and it's about being proactive. If Muhammad cannot go to the mountain, then the mountain must go to Muhammad. So please, if you hear the terms being used about hard to reach communities, I ask you to challenge it, because it can be deemed as being very insensitive or offensive, okay? But, and I said at the end of that is, I'm into equity, equality, diversity, and equity, and it's about working not in isolation and not in silos, working collaboratively. That's very important. Next slide, please. That slide, which you will get at the end, is some of the places that I target. So all of the places and even more. It's just a sample of the places: churches, mosques, gurdwaras, temples, residential homes that I target, jumbo sales, etc., to try and engage people and then put on my diabetes health awareness raising events. Next slide, please. And these are the ways I do it, by printing contact cards, t-shirts, logos, the whole list of things that I do in terms of, I'm 30,000 feet up in the air in an airplane and somebody taps me on my shoulder because I'm wearing a diabetes related t-shirt. The same when I'm going to London on the train. If I'm wearing neutral colors, they won't know who I am. And that brings about engagements. I hand people my card and then they call on me and say, yes, I want you to come to my event. Next slide, please. Gonna look at some misconceptions fake or fact. Next slide, please. It's about enabling and empowering communities to make the lifestyle changes, the behavioral changes. So one of the facts we hear out there, and I hear it a lot, diabetes is a mild condition, it's a touch of sugar. So they minimize and trivialize this condition and say, no, it's only mild. We need to get the message out there, this is not a mild condition. Number two, it's God's will. We hear that in the Christian faith, we hear that in the Muslim faith. The Bible or the Quran say you're gonna get it, so it's God's will. That is another myth or misnomer which we have to dispel. Another one, if you're fasting during Ramadan and you prick your finger to test your blood glucose levels, you have broken the fast. It's a myth. When I go to mosques and gurdwaras, I have to tell them, no, that is not right. Being big is beautiful. In some communities, and I'm not going to stereotype or generalize, but there in some communities, there is this myth that the bigger the woman is and the smaller the average or the skinny size the man is, I've found my conquered, my princess, my duchess, my queen. Simply put, you need to stop, and I say this in the communities that I go, it's not about big is beautiful, less is more. So we've got to get rid of that myth that's out there. Only people who are overweight, I hear this so often, if you're overweight or obese, they're the only people who can get diabetes. That is wrong. People of a slim, average, skinny, or in the Caribbean, we would say mager. Those of you who know what mager means, can also develop diabetes. A lot of people seem to think that if they have diabetes, or they're told they're pre-diabetes borderline, they must cut down on sugar. I want to get the message out there loud and clear. And we need to get this across to all communities. All carbohydrates we eat, starchy food, whether it be patties, chapati, yam, bread, rice, are all starchy foods, break down into our body into glucose or sugar. So it's not only brown sugar we're talking about, or the buns, or the cakes, or the ice cream, all carbohydrates. So less is more, it's moderation in more things in terms of going instead for fresh fruits and going for more vegetables on our plate. And the last one there, which I come across a lot in the 8 years of doing this, is people in their 50s, 60s, 70s start having blurred vision, which is one of the telltale signs that the blood vessels at the back of the eye are building up in terms of the diabetes. And they seem to think, oh, it's because I'm getting old. Please, I ask you, try and convince the people out there who come to you and talk about blurred vision, it's because they're getting in their 60s, 70s, 80s. No, they need to go and get a diabetic eye screening, or what we in our language would call a diabetic retinopathy screening, because it's a diabetes which is impacting on their blood vessels at the back of their eyes, which leads to, when I went to Dominica recently, so many people there were blind from having not known this is the case. Next slide, please. So those are the cultural myths we're trying to get rid of. Some do's and don'ts. I beg you, don't use the word exercise. I do a lot of these events all around the place. It conjures up images that you're asking the person to go to the gym. Say instead physical activity. I put some examples there. And these are things that I do. Fast-paced walking, gardening, jogging. I go to a Zumba class every week. I've done for over 10 years. I go to a yoga class every single week. I go to a Pilates class every week. I can't do swimming, but I go to an aquarobics class. And these are things that I do. I don't do the lifts or elevator or the travelator in the supermarket. I climb the stairs. Your feet were made for walking. Encourage people to park the car, form a walking club, 3-4 of you, meet each other, enable and empower, gear people to go and do physical activity. Recruit volunteers, both community champions and ambassadors. I've been doing it for 8 years. And the more of us out there to alongside the healthcare professionals, the better. Pro-social modeling, which means leading by example. If I was 30 stone, I couldn't be asking somebody, by the way, you need to lose weight. So I have to lead by example by making sure that my weight is at a level where I can then get that message across to people about keeping your weight down. Seek out religious places. Don't go to the imam, the rector, the vicar, the pastor. They have too much on their minds. Within the church you go to, find out who leads on health and well-being issue. It's over time doing this for 8.5 years that I've found out those are the people you need to go and engage with, and they will set up the session you want to do with them. Now this for me is key. Keep the language simple. Cut out the terms, cut out the jargon, cut out the acronyms. And a classic one I hear all the time is impaired glucose regulation. Say to a person, the average person will not know what impaired glucose regulation is. Say you are pre-diabetes or borderline. That will give them a better idea of what you're talking about. So you need to be careful. Digital or diabetic retinopathy screening is another one. Somebody heard it the other day and said, oh, you're talking about ice cream. Ice cream is different from eye screening. So make sure you use the language that they can understand, please. It's so important. And not up there with the fairies. Next slide, please. Literacy. This is a major issue, not necessarily only in the African Caribbean community, in the Asian community, and to some degree in the white community. My wife is a teacher. She taught at a primary school for 25 years. When a patient comes in front of you in your surgery, your clinic, or when you're going out, and if you hear them say, I forgot my reading glasses, there's a clue there for you. A lot of the times, it's not that they've forgotten their reading glasses, or you're trying to engage with them on a one-to-one, and they're looking non-verbal communication, they're looking away and they're looking sheepish. You need to be conscious of the fact that the person might be illiterate, is unable to read and write. So when I do my training out there and I start to hand out quiz papers and the person whispered to me, I forgot my reading glasses, I just take all the papers back because I know I'm in a situation where the person has literacy problems and it's not up to me to embarrass that person. So I do it loud on the screen and talk through the answers. So be mindful of that. You might think, oh, this person isn't engaging with me. It might be to do with literacy issues. Next slide, please. It's a well-known fact that the 4 T's, the tired, the toilet, the thirsty, the thinner. I developed those 17 years ago, but I was typical of most men, and this is where you're gonna have to come into the equation. Most men don't do doctors. Most men are not in touch with their emotions. It's up to us to try and engage with these men. Men are like the ostrich, buries its head in the sand at the first sign of danger, hoping that the problem will go away. So we need to be mindful of those 4 T's, which I was displaying, and my wife said, something's wrong with you, something's wrong with you. I was in denial, getting up 2-3 times. I don't mind this being recorded, 2-3 times a night to go to the loo. Then in the morning, I'd be tired, lethargic, and so on. So the toilet, the thirsty, the thinner, plus slow healing of cuts and wounds, which is why when people have a sore foot or so on, they need to be mindful and need to make sure they keep their feet in good tip-top condition. It's about empowering and encouraging patients to make the lifestyle changes, because sometimes somebody can have diabetes for 10 long years in their system and have no idea, no tired, no toilet, no thirsty, no thinner, and then suddenly the horse has bolted and the blindness starts, the blurred vision, the strokes, the heart attacks, the kidney damage, and the limb amputations, and sometimes early or premature death. Black people, and when I use black people, I'm using that in a political context. So African, Caribbean, and Asian people are 2 to 4 times more likely to develop diabetes than white people. And look at the age, from age 25. White people on the whole tend to start developing it at age 40. So that's 15 years early. And people ask me, Tony, why is that so? It is to do with our DNA, or genetics, or metabolism, or makeup. Why we're more susceptible or prone to developing it earlier. And I'll put a little question, and you should be able to answer that. At the bottom, train drivers, lorry drivers, bus drivers, taxi drivers, all have, and that's fact, a higher rate of diabetes. Why? Think. They are leading the sedentary couch potato lifestyle, where they're not up and about, not doing movement, they're sitting down for so long. The chances are that's the main reason for them getting diabetes early in life or later on in life. Next slide, please. Now this, I've been told by the NHS who I work for as a volunteer, I must put it in there and mention it. Before COVID, most people would go and get their blood testing done, the urine plus the blood, which would give them the proper analysis as to whether they're no risk, low risk, medium risk, or high risk. with lockdown and everything, we are inviting people to make use of the Diabetes UK Know Your Risk tool. You put in your height, you put in your weight, you put in your ethnicity, you put in your gender and your age. It can actually work out for you even before you head to the GP. And then you can then make a self-referral. If you notice, hang on, the results are showing from this Know Your Risk tool, which is on the diabetes.org.uk website. It can actually determine, even before you go for a blood test, where you are on the scale. And I urge you to try and get out to communities with this message. This is one of the most important slides. And then you can reduce your risk by eating a healthy, balanced diet, be more active. We're talking about movement, movement, movement. Even elderly people, when I go to the residential homes, they say, but Tony, I can't get up and say, well, you can get cans of beans. And all you do is lift them up, just like that. That's physical activity you're doing. You can also get plastic bottles, not glass bottles, plastic bottles with water, fill them with water, and those are your dumbbells. You're not going to be Arnold Schwarzenegger at the end of it, but you've done some physical activity. You can stand up, try and be patient with them in the residential homes, but get them to stand up every few minutes and sit them down again. If I had my way, you know what I would ban? The remote control. When I came to England, I'm British born, but grew up in Jamaica. 79, I came back to England. And then every time you had to change a channel, you'd get up from your seat and go over and change a channel. Now all I see is beep, 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 remote control. You know what you do for me? Hide the remote control or put dead batteries in it or take out the batteries. And I'll encourage people to get up 4 or 5 times during an hour, doing that and changing the channel. That is physical activity. That is movement. Next slide, please. I don't need to say anything about stop smoking. We know. Gender differences. Most women have no problem. Anytime a little ache or pain, they will head to the doctors. Men are the complete opposite. We need to encourage our men to go out there and engage with the healthcare professionals. And once they get through the door, you've had them hooked. But it's that first initial reaction. We need to make that extra effort. Pride, it's this macho manly thing. And they suffer in silence, which we need to. Men are always in denial, suffering in silence. Men are too embarrassed to go and talk to their GP about any issues. We need to encourage them, seek them out, help them, advise them. And once you get them in, then they're hooked. That's very important. I can't but stress that. Next slide, please. I'll just give you a very quickly personal experience. I have what is known as the sickle cell trait. So I cannot do the HbA1c test. In the first 2 years, they used to prick and send it off the blood, and they'd call me back, Mr. Kelly, Tony, it didn't work. I said, why? It just didn't work. I asked my doctor after year 3, why is that? If you have the sickle cell trait or thalassemia, which a lot more Black people have the sickle cell trait, not the full-blown sickle cell anemia, you have to do the fructosamine test. They actually have to put that word on the vial when they're sending off your blood sample. It can only tell you what you've eaten in the last 2 weeks, as opposed to the HbA1c test, which tells you what you've eaten in the last 3 months. We need to be aware of that. And I go, sometimes I have my blood test done, and some of the nurses there, and when I said, what are you going to put on the vial? HbA1c. I said, no, you're not. And they said, well, are you a doctor? I said, no. But nobody knows my body better than me. Put fructosamine. And they said, but Mr. Kelly, we don't know how to spell it. So I ended up having to spell it out for them a lot of the times. Pernicious anemia. 2 years ago, I was feeling very tired and listless. So I thought, unlike previously when I first became diagnosed, I hadn't been to a doctor for 8 years. That shows how I didn't just do that. But 2 years ago, pernicious anemia. I went. The doctor said I have pernicious anemia. I said, what's that? Lack of B12, vitamin B12. And I came home and they kept ringing me for about 3 days on the trot. Mr. Kelly, you have to come and get an injection. You have to come and get an injection because you will go into a coma because you have type 2 diabetes. I went down and I said, how often will I get the injection? Every 3 months for the rest of my life. I just looked at the doctor and said, that is not going to happen. So I went away and I looked up what pernicious anemia was and what I need to eat more, like fortified cereals, more egg, more crab meat, more prawns, etc. And I also get from Holland and Barrett, any other drugstore you can get it, I get Floradix, which elderly people tend to use. It has all the irons and multivitamins and so on in it. My wife, she prefers the Metatone tonic. I do Floradix. I went and I get the Holland slow release 1 a day tablet, B12 tablet. I went back to my doctor 3 months time. He said, Mr. Kelly, it has shut up. It's okay ever since. And I actually jokingly said to him, so why would you want to stick a needle into my bottom in my backside every 3 months? And that's what I'm saying. We can save the health service a lot of money if people are more assertive, if people ask questions, if people open their mouth. My grandmother taught me when I was growing up in Jamaica, she said, you're a bright little boy, open your mouth and ask questions. That's what they're there for. And if you need somebody who needs to be an advocate or mediator, then let somebody go with you. Kidney stones was another issue. 15 years ago, I had the most almighty pain, went to the doctor, they sent me to the QE, I passed the stone out, and my mother, who was a nurse, she passed away now, she said, you must stop drinking cow's milk. A big man like you, you're not to drink cow's milk. It's for young children, for bones and teeth. So I have coconut milk, rice milk, almond milk, and oat milk instead. And those are equally good for me instead of having cow's milk. Next slide, please. I think I'm coming to the end now. So those which the Professor Wasim Khan mentioned, Hanif mentioned, heart disease, kidney disease, diabetes, hypertension, dementia, and lack of vitamin. I am not for 1 minute denying that these commodities don't exist. What I'm asking, and I put it in red ink, never lose sight of the following: systemic racism, disparities, of health inequalities, and socioeconomic factors, because those are some of the fundamental underlying issues why more African, Caribbean, and Asian people have succumbed to this COVID-19 thing. We need to be mindful. This is the same in America that's happening here in Britain. We need to go there and educate our communities more, especially our African, Caribbean, and Asian communities who are more prone, more susceptible to having all of those diseases mentioned there. Diabetes is a medical condition, but it's up to us to educate them and say, try and build up your immune system to ward away these various things that might cause you to get the death of COVID-19. Next slide, please. And these are just some final thoughts to share with you. Perseverance, you've got to be key. I knock on doors, on temples, wherever, mosques, good warriors, and they say, oh, come back. And I go back 3 months' time, and I'm persistent and persistent. And they say, gosh, you really are persistent. And I say, it's free. It's not costing you anything. Don't give up. Never readily and hurriedly accept no as an answer. Habits are easy to make, but hard to break. Show empathy. You're not showing sympathy in this situation. Just put yourself in somebody's shoes. It's not a one-size-fits-all. And always remember to enable and empower people. They will fall off the bicycle. They will relapse, but they get up and you help them along again. And these you will get when you get the slides as well. And then to end with, next slide, please. I end with what I call equality, equity, and liberation. My background for 30 years was on equality and equity and diversity person, middle manager. And we start with equality. Notice the 3 young boys are on the same level. So the tallest chap, he's seeing the football game or the baseball game. The one in the middle is seeing it. The short boy is not seeing anything. Equity is different now. Equity is when you decide to give the one who is the shortest 2 boxes to stand on so he or she can see the full game. The one in the middle just needs 1 box. The one at the far left doesn't need a box at all. So what I'm asking in terms of liberation, remove the barriers, the obstacles, the hurt. You don't need the fence there. Remove the barriers, the obstacles, the hurdles, so they can stand and watch the game. It's the same out there in what we are doing, and get on with what has to be done. And on that note, I end. Thank you very much.
Thank you, Tony. Ooh, sorry, I think I froze. Thank you, Tony. That was great.
I think my next slide would actually have my email address. There we go. My email address, if anybody wants to contact me and say, Tony, I've done so many webinars because of the lockdown, quite a lot. And I'm available free of cost to do them in the comfort of our home here where we live. Call on me, please.
Thank you, Tony. It was great. And I think some really actionable key messages for everybody to take away and think about how you can use them yourselves or use them with your communities, particularly breaking down the cultural myths and making sure that you use a simple language that everybody can understand. Also, Tony mentioned getting more active, eating healthily and stopping smoking. We've got webinars that focus on those later down the series as well. So if you tune into those, you can get some real practical advice and guidance and talk to some of the people that deliver some of the things locally as well that can help with all of that. So Tony, I believe, is around with us for the next...
I'm saying to the end.
Yeah, to the end. So there's lots of people writing nice comments about your what you've said in the chat, but if you have, we'll keep an eye on the questions, and if there's any questions come up, we'll bring them up at the end. So thank you, Tony, and it's time to move on to the next slide, to the next speaker. So today we have Cam Padden with us, who from Health Exchange. Unfortunately, Jennifer Jones-Rigby is ill, has been taken ill today, so Cam is here with us today. Cam, do you want to join us?
Yeah. Hi, I'm Cam Padden. I manage the Birmingham Solihull Type 2 Diabetes Programme. Right, so today I'm going to talk about managing your diabetes programme, supporting self-care and empowering patients for we've been doing that for over 11 years now. Should we go on next slide? Right, what the outcomes and objectives are is all about supporting self-care and empowering patients through high quality education and self-care resource and programs. Now, the aim of the Managing Your Diabetes program is to provide a structured patient education to individuals who have difficulty managing their type 2 diabetes. And this will be done by the following NICE guidelines, CG 66 and CG 87. Next slide. Right. Due to the COVID, we've not managed to do any face-to-face community setting programs. So instead, we're doing Zoom groups. Now, the Zoom groups are done over the weekends, telephone support, emails. Now, what is a Zoom group? Zoom group is we get patients, clients to send us their emails, send them a link, and they can join us up to 4 weeks, in which they will join our Zoom groups. We'll talk to them about how to manage their behavior, manage their activities, talk about physical exercise. Like Tony said, we don't use exercise, we use physical. We talk to them about walking. We try not to sort of make them worry that they have to go to the gym. We offer them telephone support, emails, posting information, depending on what the patient's got, because we've got a lot of elderly patients who don't have internet, so we have to work according to their needs. Now, we do reach people all over Birmingham and Solihull. They've increased the area, and now we've included Sutton Coldfield, so we cover Sutton Coldfield, Solihull, Birmingham. There is parts in Smethwick that we do our programme for. Now, the patients must be, it's okay, the patients can be 12 months plus diagnosed with type 2 diabetes. If they've never been offered and accessed the education, structural education program, they can actually come on our program. Do you want to go to the next slide? Right. What we do, each year, we work with over 800 patients to provide them a structural education program, self-management, with a type 2 diabetes program. Now, these are some of the comments we've got from patients since October to December 2019 after they completed the program. As one of the patients put down, I've implemented a lot of information from the course and can honestly say it made a positive impact on my health. Now my metabolic has increased as well as my energy levels. I am pleased with the outcome. I mean, I've had one patient I just spoke to recently who'd been in our program 5 years ago, and she spoke to me and said, I'm so pleased. I lost over 3.5 stones just watching and being careful with what I eat, but I can eat anything I want to, but as long as I cook it healthy and watch, and I don't eat my cakes and chocolates too regular and keep it as a treat. So, I mean, this is just recently I've had somebody say that to me. Right, somebody's put down, I was very happy with this program. This program helped with my diet, exercise, gave a good understanding on diabetes. So we do, after the program, get them to fill in a survey, questionnaire, and they give us what they think on how they felt and how it's helpful, and if there's any changes we need to make to help and support them. Do you want to go on to the next slide? Right. Background to the approach. Now, Health Exchange has provided the type 2 diabetes management structural education program over 11 years, right? It's going on to our 12th year. We do access a lot of patients now. It is confirmed to the NICE guidelines. We do have a program manual, what we go on day 1, 2, 3, but we can change some of it depending on our patients. Say if we have patients whose first language is not English, we do get interpreters. If it's Punjabi or Hindi, some of these languages, myself, my colleague can actually provide for them. If not, we do get interpreters. And at the moment, we're getting a lot of our patients who've got family members who can actually interpret for them, or actually sit with them and help them, support them at the moment. So it's been quite different, a different change from what we've been doing over the past few years. Next slide. Right, this is just some information on the impact it's made, how it's helped the environment, the NHS avoid medication. If we can help and manage patients to actually manage and control their diabetes, it prevents them from going on to more medication, helps them developing more problems and complications further down. I know that Tony's talked about a lot of things going there, being an advocate, and that's really good. So can we go to the next slide? I can see what I'm reading from the information people sending, which is really good. Right. Managing your diabetes referral criteria. Now, if you want to refer someone to the program, they have to be allocated in Birmingham and Solihull GPs, some of them in Smethwick, a bit in Sutton Coldfield. So we do have a list. Now, it's those people who have been diagnosed with type 2 diabetes in the last 12 months and plus. For this year, we're actually letting people who are a little bit longer on diabetes due to the COVID. We have a little bit more time where we can let a lot more people access our program, which has been really, we've had a lot of people come along and say we couldn't manage to go on this program before, but we've now had the opportunity, so that is good. Now, who can refer? Your GP, practice manager, diabetes nurse can refer, and you can do self-referrals also. Now, what they're doing now, the GPs, is sending us a list of people who've been diagnosed with the type 2 diabetes. We're making contact with them, sending letters and telling them if they're interested, they can jump on, because when we do Zoom, we can actually offer the program to a lot of people. A lot more people can actually come on a program. As when we did face-to-face, we actually found we could only have a certain amount of patients due to the room space, and at the moment when we do go back to face-to-face, we will only be able to allow about 6 or 7 patients at one time due to the COVID. Next slide. Now, what has COVID meant for our delivery? We've had to change our delivery. We've done Zoom, emails, telephone, lots of different types of support, but we've actually had a lot of people who actually preferred it this way to doing face-to-face, because we were worried when we couldn't, patients were worried because they've got the underlying health condition and they can't actually come out their home. Would they be able to attend? Will we be able to support them? And to be honest with you, a lot of people we talk to have never been at the home since they've COVID had started. So when we ring patients, they're actually pleased to hear from us, and they can actually tell us a lot of them haven't had blood tests done. So we actually advise them what to do. Right, what we've done, we've adapted the way we deliver. And like I said to you, we're doing Zoom, we're doing telephone one-to-one sessions. So we post them information, do emails if they don't have links and they don't have internet. Zoom groups, we've had that's been very popular. We've had a lot of people attending. With Zoom groups, we can actually do evening support, weekends. They can tell us different times we need the groups, and we can actually do them, as it was quite difficult when you did face-to-face, and they don't have to travel, so it's easier for them to just log in, join us, or like I said to you, do through telephone. Now, materials are sent out to all participants by email and post, and links. a list of GPs to support increased access to structured education program, and we've had so far 412 patients across Birmingham Solihull who've already been on our program since March this year. So we have a target of 850 patients by the end of March 2021, but we've already gone more than halfway, so that's really good. I mean, this helps us to think differently over the next few years. When we deliver our program now and in the future, we will think about all the different opportunities. So it won't be just face-to-face, it will be Zoom and other ways that we can actually deliver it, which is more effective and efficient to patients. Next slide. Right, now some of the things that people have said to us is, since we've had the Zoom, mainly people who have been shielded during the COVID-19 can actually join. People who are less mobile, people who can't walk, in wheelchairs, couldn't come to our program, found it difficult, but now that they don't have to travel, can actually join us by Zoom. They can get their grandchildren or family members to actually join in with them and actually access it and have the extra support. It also saves them time, travel time and expensive. It helps people who are on benefits, so it saves money in the long run. Helps individuals who have mental health issues. Now we actually run, we have actually a program, mental health. So when we get patients who are type 2 diabetes, we always refer them, if they need more support, to some of our other programs, such as mental health and social subscribing. So it's really helpful in that sense, because we have patients who have anxiety, but this way they can actually join us in the comfort of their home and don't have to mix in with other people. Some people are actually shy and nervous, so they don't actually show their face. They can switch off the video and allow audio. Zoom is good for individuals with visual impair who can't see because they can actually hear. The conference allows them to interact, live audio interactions. I mean, some people who don't actually have internet, we actually let them join by phone. So we do send links by phone, text messages, other ways which they can actually listen to what's happening. Clients who are working, this has actually been quite good for them, because some of the people who are working, going out to work, can actually join our Zoom groups, because they can take an hour out and join instead of having to travel to our venue. Now they can sit in their office, join us for an hour and go back to work. We do get a lot of patients from our care homes, the carers, the nurses who've been joining us, and it's been interesting for them because they can actually, while they're working, get their patient to sit down as well, listen while they can take an hour out. So it's been good in different sense. Now, like I said, these groups are delivered during the day, evenings and weekends, so it depends what is required. When we ring a patient, we do ask them which time they prefer, which is convenient for them. Now, having the groups, you can have it in the comfort environment, in your home, more relaxed, more focused, and gives you, a lot of patients feel more confident to interact when they're at home, instead of having to be in another place with a lot of people and feeling uncomfortable. Like I said, it saves money. And it also, you get someone at home, you can actually translate. Sometimes they have like their grandkids with them, daughters. A lot of Zoom groups have had people with other members, their partners, because they want their partners to listen so they can actually cook healthier as well. Because they said, if I get a gentleman, he'll say, can I get my partner to join? Because in the future, when they're cooking at home, they'll be doing the cooking, and it's helpful for me to get them to listen to. Now, you can actually receive online chair exercise. One of our tutors are actually Extend tutor, so she goes through the Extend training as well on what they can do with a chair, sitting in the comfort of their home, yoga exercise on Zoom. This helps them control their weight, blood pressure and diabetes. Also, with older patients, they always had difficulty coming to our groups when they had if they had bus passes, because they wanted to start after 9:30. Sometimes they couldn't make it because the bus came late. So this way it's easier for them. They can join in any time as well. Can we go on to our next slide? Okay. Right, that's it. Now, if you've got any questions, just ask, and we can have also, you can email me if you want referral forms or anything for your patients. Okay, thank you.
Thank you, Cam. That was great, and kind of a practical service that people can get involved with if they want to, which complements everything else we've said today, which was brilliant. So I'm conscious of time and that a few people have had to move. I'm going to turn my camera off as well because I keep freezing. So there's on the slides that will be shared afterwards, there's just some useful resources for you all and some key things to look out for and some links for you to share with community groups, most of which have been talked about today as well. Some translated information as well, which should be of help to everybody. The other thing just to mention today, whilst you're out there talking to communities, we have also launched our COVID Health Champions programme. So we're asking people who work within communities to sign up to be a COVID Health Champion across Birmingham. We will then share up-to-date COVID information, so it might be around guidance, it might be around, it's any current information that we're trying to get out to community groups to protect them. So if you're working within communities and haven't signed up, this is a really, really good opportunity for you to kind of get the up-to-date COVID information as well, to add to the work that you're doing. So you can see on here, there's a little bit of information, but also the web address at the bottom to register, and we'll make sure that goes out on the follow-up email as well. So I think I can see some questions coming in, so I'm just going to flick over to the questions. Our question slides seem to be missing. So we've got Jazz has just come in with a question. I'll read it out and then we'll see who's best placed to help. Just a random question. I'm wondering if there's been either a rise in diagnosis of diabetes as a result of the pandemic, as people were locked down, increase in unhealthy eating or lack of exercise, or a decrease in diagnosis rates as people were less active or less accessing GPs less. Sorry, that was awful reading. That's a really good question. I don't think we have the information available to answer that. I know.
I think I can answer. Sorry.
Yeah, no, go on.
I
That's
can
fine.
slightly answer that. Because during lockdown, I wasn't able to do any of the activities that I do weekly. When I had to go back for my diabetes checkup, the nurse said and the GP said I put on the sum total of 4 pounds in weight. But they both said to me, gosh, you're the exception to the rule. Because of lockdown and people staying at their home, I used to go for walks with my wife and we go out these hills and gradients and valleys. Most people were sitting at home, eating and getting very depressed with all what was going on and so on and not doing any physical activity. And they were explaining to me that there has been a massive increase in the amount of people who have put on so much weight that they're now either borderline or have tipped and gone into getting diabetes. So the lockdown has had a major impact in terms of people not being able to be healthy and out and about and so on. And that was just one doctor and her team telling me that at that surgery. So I would imagine that might be across the board. Anecdotally, I'm talking, by the way.
No, thank you, Tony. Yeah, I think we've heard other things.
Can I add something into that? Can I add something to that? Yeah, I do agree with Tony. A lot of the patients I ring haven't actually managed to go out to get blood tests done because they're shielded, and because they're sitting at home alone in flats. They've not done any physical exercise activity, so we do try and encourage them, try and tell them things they can do just in a small space. But yeah, you are right. A lot of people have been putting on weight, comfort food, because there's nothing else to do, boredom. So yes, it has affected a lot of people.
No, that's great, thank you. And I suspect there are actually some proper figures on that as well that we can access. There was some information at the Health and Wellbeing Board at the last meeting that touched on services and service use during COVID, so we can have a look at that. Okay, I think the rest of the information in the chat is all big thanks for all the presentations that everybody's done today. So if I have missed any actual questions, if you just want to drop them in to the Healthy Brum email address, we'll pick them up later. As always, you can get in touch with us there and access all of the information for the webinar series on the Birmingham City Council website. Okay, I think that's all for today. A big thank you to everybody who's spoken and contributed, and to everybody for coming along and listening. Hopefully we can get some of these messages out to communities as well. So that's all from us today. Thank you very much, everybody. Bye-bye.